All right, so we go on to the next case. Is a 56-year-old male and right-sided weakness, aphasia, NHS 16. He was thrombolized and strictward thrombectomy. So this is the CT angio, and it showed left ICA occlusion, small infarct. That's the AMR. Can we speed up the video? Okay, so this is the neuron max guiding we took in, and we did try to aspirate a bit. Just not going to work. So in this case, there was a tapered occlusion on the CT angio, and we strongly suspect it's probably a young man, uncontrolled hypertension. It's a dissection or not. Or you can see there's a large amount of clot sitting there. This is the other view showing again the same IC occlusion. Rashni was the guy with me doing it. We did check for collateral in these cases. This patient was a poor patient. We knew stenting going to be an issue. So we knew there was a great ACOM. So the first was, okay, that, all right, stop it. All right, etiology here, whether, all right, we go back. Again, etiology, what would one suspect? Is a dissection, or is a large clot sitting in the ICA, or is ICAD? Matthew, I mean, what would you thinking of at this point of time?
No, I mean, the history is very suggestive of dissection.
Yeah.
So I would still start with, see, for me, I always look at the MR. If the T1 is showing hyperintensity, I would always think. Right. But having said that, I would probe with the wire. I will not be aggressive. I'll gently try to see how the wire moves. The wire is your finger. Is it making a loop there? Am I making a dissection burst? But I will definitely try to cross it with the wire.
Yeah. So we tried crossing it with the wire. All right. Initially, we give one try, and we use the same approach as Vincent mentioned. We use a 5F catheter to angulate and try to cross it, but with the regular 3.5, we just couldn't cross it. So we switched over, but we did take a neuron max a bit in to help us there. And then we decided, we tried, it didn't work out. Then we switched to a microcatheter with the Traxus wire, and it seems, once you can always get a feel when you reach the lumen, it became free. And we thought probably we are in the lumen patent artery above, and that's a microcatheter. We could track it. As you could see, most of these cases we do under local anesthesia. Vincent did mention maybe in tandems we can switch to general anesthesia as well. So once the microcatheter is there, we are almost to the cavernous segment. We've gone through the petrous and lateral segment, and we wanted to check whether we are in the true lumen or not in this patient. Yeah, it was quite free and in both planes. And then we knew we wanted to get a guide systems up there. Okay, so initially we tried whether with an aspiration catheter we can go over the microcatheter, and so we tried over a bigger microcatheter whether we can take our aspiration catheter, but somehow I think the underlying tortuosity of the ICA, we were not successful. And we tried quite a few times, it didn't work out. No, we thought this is dissection, so there is no point. All right, so we took a 4-4 over a stiff wire, and then we took a Navian. I mean, that can something which we can discuss. And once that system was there, and we took a Navian catheter up, and you can see it was them, and we took an Emplart's wire in that 4-4, and then we could get our systems up there, because I want to good base camp up there in the petrous ICA to have to do the intracranial thrombectomy. So that was 4-4 with Emplart's wire and then Navian, and then we could target the neuron max. I took it across in this case. Vincent mentioned we went across because I thought I'm not going to cross this lesion again and again. And then it's a standard thrombectomy technique. So we again, sometimes crossing the clot can be an issue. We just push the microcatheter, it went through easily. And we deployed the solitaire, I think 440 in this patient. I think that's React 7.1. It navigated pretty easily, but it's great to have this great base camp of neuron max in the petrous ICA. And whether I think I can just speed up a bit. No, I'm not able to. No, I can't change the speed of the video. And we checked. This is a standard approach. We just give a very small dye injection to know then the patent artery, and then deployed the solitaire, 440. We sort of use push and flux technique. We deploy the initial part, and then we tend to push out the solitaire, try to engage the clot a bit more, and then we take out the micro and take the aspiration catheter a bit more to try to pinch the clot a bit with the aspiration. And then we wait for a while and take out the whole thing. So in a way, that's our standard approach in most of our cases anyway. And we take it out slowly. We don't pull out very suddenly. And under aspiration, with both the neuron max and the aspiration catheter, okay, we get a great recanalization. And now the question which we were discussing, to stent or not, what to do with the lesion here. Since we were suppressing dissection, you could see the artery is probably loopy. And we were happy there was no major embolism. The ACOM is patent. Most of the arteries are patent. We have already checked there was a great ACOM in this patient. Okay. And doing aspiration, yes, we aspirated when we brought it out. In fact, what step we have missed, we kept the wire initially, traxus wire, to have an access. This is later on when we had finished the procedure, we took out the whole thing. And IC is still occluded. It's a typical thing, it's beyond the blurb, tapered or closure. And we know it's a loopy artery, it will mean placing multiple stents. There's a great ACOM present here, which takes care of the perfusion, and we didn't do stent. As Vincent himself mentioned, in dissections, the data is clear. I'm sorry, it's coming out as native. So all arteries were filling very well from the ACOM region. And that's the CT scan of the patient. It showed only a small infarction. He made a dramatic recovery, actually. Thankfully, it didn't take us much time. So in dissections, we don't try to stent because the data clear. When there's a great ACOM, and stenting here is complicated. It's a loopy artery, will need multiple overlapping stents, and okay, it's playing again. So, and we are, all right, so in this kind of case, we avoid stenting in dissection patients.
So that is the answer to the previous question.
Previous question, yes.
If the collaterals are good. And
so in dissections, number one, okay, stenting is complex. In dissection, the data is clear that stenting doesn't add to the benefit. Okay, there may be situations, we'll show you a short case, when dissection is a hemodynamic problem. And dissection patient with a hemodynamic issue, one may need to stent. So in dissections, usual approach is avoid stenting, as I said. The data is clear, there's great ACOM, PCOM. Medical therapy, the recurrence rate is pretty low. Vis-a-vis, as Vincent mentioned, in tandem occlusions on medical therapy, the repeat stroke rate is quite high. So yes, in Ugawa literature, in ICA stenosis, if you are in trouble and it's not remaining patent, stenting is the answer. While dissections, in most of these cases, we can avoid it. Yeah, Tufel, I think you want to say something.
I'm not sure. I think I would have stented that because the patient on the table and you still have collateral, you don't know whether he still has got hemodynamic, still compromise. In terms of clinically, that might not be enough. And you don't know that. So when you have already crossed that and you already got a very good access and the patient was 3.5 hours, this patient was 3.5 hours with a very good, very good aspect score. You may argue, why do you want to not keep that artery open? Because you know when you come out, you're going to lose that artery. So, and that's what has happened. So I take your point, but I probably would have landed up putting a stent there.
Okay, let me talk to
and
practically.
I'm just not,
It's a great ACOM. I checked the venous delay. There was no venous delay on the other side. To me, like in carotid occlusion, yeah, we won't stent it, number one. Number two, stenting here means multiple stents. Number three, patient didn't have money. Even thrombectomy, we had to get the devices free. So I was very happy I didn't have to stent. So let's talk about practical Indian situations there. Yeah.
But
yeah, once you place stents, you don't know what you are entering into.
Yeah. So for me, the bleeds post-stenting, and some of them are terrible ones. So the choice is, will he reinfarct versus a bleed? The chances of him reinfarct is very low, very good ACOM. I could see that the vessels are filling. I think your venous phase would have been almost instantaneous.
Yeah.
Seriously, I would just wait.
Yeah. I think, Vincent, please agree with me.
Yes, I think the data are pretty clear. I mean, if you let a dissected vessel in position under medical therapy, you can fear things, but the data is less than 3% stroke recurrence rate at 3 months. This is the data. They are young patients most of the time, so the collateral flow is extremely efficient. Letting an occlude carotid at 70 years old is maybe much more risky than at 40 because the readaptation and the cross flow we saw was just very strong. You know, when we tried to make the flow, the run into the MCA, whoom, it was washed like never on the. So I would have done the same in terms of not stenting. And so, again, you are saying we can just drop a stent. We cannot just drop a stent. I think the maneuver he did with the penumbra to the skull base has boosted the dissection to the skull base. It's like 4 stents. And believe me, I'm doing carotid reconstruction a lot. Here you cannot sort with just 1 stent. You need 4 stents. 4 stents, just aspirin. What do you do? No, here you have to be with
loading with drugs.
Yeah, you have to be very aggressive after on antiplatelet therapy. Huh?
Okay, so let's have a raise of hands here among the audience. How many of you stent the atherosclerotic tandem occlusions first approach as stenting? How many of you? I'm raising hand just to ask. I don't do it. All right. All right. So, yeah. All right, few. And what about the dissections? You like to stent them after recanalizations?
Actually, the question would have been like the collaterals plus tandem occlusion. The collaterals are there because individual patient.
Ajay, you always ask a question which tells us to go to the next case. So let me start the next case. About some of you know what's going to come, right?
Yeah, I don't know.
He's a good friend of mine. He knows what I'm going to do. So let me just quickly go to the
Vipul
next
sir,
case.
I just wanted to add one thing for the residents and newcomers. This case was very beautifully done by Dr. Vipul, which is very much expected. But the use of implants in the carotid system has to be very much cautiously. And you might not have focused on that Dr. Vipul never took out the implants out of the catheter. It was just inside. So you have to take care of this point that implants has to be inside the catheter. You are just supporting it from inside. The implant tip should not come out because it will perforate, it will dissect further. So this is something which I wanted to add for the residents.
That's a very, very pertinent point. Hair crossing was a big challenge. We changed from micro to bigger micro to a stiff wire, then 4/4, then Navian. But I didn't want to cross this lesion again. If I cross it with the aspiration catheter, I do thrombectomy, but I lose the access. It's going to be a challenge to get in again. So let me go on to the next case.
Vipul, can I ask you a question?
Yeah, please.
So in your case, once you had recanalized, you had kept the wire up. So and then you did all your runs. You knew the artery was occluded.
Oh, yes.
Yeah. But then you went on the right side.
Oh, no. Okay. So right side we had checked before. Because see, okay, this patient is a worker brought in by his colleagues, had no money. And this is real life, right? Now, how do I say no to a young guy with few hours of stroke and no money, no family there, but how do you say no? So we just decided to go ahead with it anyway, and in Indian circumstances. So it was in my mind, if I come to stenting, I'm in trouble. There is no money. Thrombectomy, I can manage. So we checked the ACOM beforehand. I knew there was a great ACOM. So we had checked it beforehand. Only thing is, and we kept the wire across. So in all these tandems, we keep wire across, we withdraw the guiding so we have an access. But we have checked the ACOM beforehand. That is great. Okay. So we knew that. In fact, I showed you, I went through quickly. We took a quick run of right. I said there's a great collateral and MC occlusion. So it was in my mind, as long as this man, poor man, I can just get the MC clot out, maybe.
Sure, but my question to you is, if the ACOM wasn't there and the collateral wasn't very good,
then hospital will have cut off half of my
then you're obliged to stent it.
Yeah.
So I think your point is well taken. I take the point that if you got good collateral, then you may consider not to stent. I may not agree, but that's a good point. But if you don't have a good collateral, and if the patient is in the general anesthetic and you don't know how his NIHS is going to be, how improvement is, then you are potentially risking.
And you realize in Indian circumstances, like Vincent mentioned, 4 stents in acute situation, it can be trouble. So let's go on to the next one.
Dr. Vipul.
Vipul, just one thing.
I'm sorry, Matthew, we are running hour
I
late.
just want to tell, I always keep a second catheter on a lesion like this. I do not come up without seeing that last bit.
I'm not able to stop this somehow. Okay, so this is the another patient, fluctuating patient. Again, we took a contralateral injection, so some watershed infarctions. And there is ACOM here, but doesn't look that great. Okay, this is the key here. You can see some delay on the right side. And he was fluctuating. We tried to keep him conservative. We checked for the PCOM quickly. Again, some left-meningeal collaterals. And this looks like, okay, this is what dissection would look like. ICA, tapered off, narrowing, what we used to call as rectal appearance. So should we just increase the blood pressure or we do ahead with stenting? We had kept this patient conservative. He was not. So we took excess 9F short sheath, balloon guiding 8F walrus. We want to be ready for a stenting if need be. And then initially we took aspiration catheter. So that's the guiding and under inflation of the balloon in the proximal IC. I didn't want more distal embolism. MCF was patent, right? We just took the Sophia across while aspirating. Something like what Vincent mentioned, goes across the stenosis, keep aspirating through the ICA. And then we took another run. You can see some flow in the IC. We can see the dissection there as well. And then we decided here is not going to work out. Matthew, as you mentioned, angioplasty. He knew this is hemodynamic issue. And you can see a false lumen there. When we cross with the Sophia, so you have to be very careful. Vincent discussing how to find the true lumen in dissection. It's kind of a separate topic. You have to be very careful to go through the true lumen. And then we did some angioplasty. But you see, we kept the balloon guiding inflated. I didn't want to have more embolism going in while I'm doing all. It's like proximal control, proximal flow arrest. Angioplasty doesn't really matter much, I guess, in these cases. And we use a 740 wall stent. Wall stents are useful. They can become much longer than 30 or 40 carotids. And they're pretty easy to manipulate. Sometimes we use a coronary stiff wire to keep them stable. Sometimes tortuous arteries is useful. And then we deployed it and did some more angioplasty. So this is the classical case of hemodynamic. In these cases, there is no choice. And we reconstructed the artery and patient did pretty well. So these are the situation dissection when it's hemodynamic. Then we have to switch to stenting. And I'm very sorry, we just are running out of time. We have a long program. So we'll switch on to the next section, which is ICAD. We can have one comment. When I say no comment, nobody wants to comment. Yeah, just to show the crowd, I mean other people, that yes, there are situations we have to be stenting, and what approach we take in these cases, balloon guiding, initial one aspiration maybe, but under balloon guiding aspiration, and when we love to use wall stents because they can be, even Rene Chapeau has shown he takes wall stent up to the Petrus IC as well, and these are much cheaper than trying to use our neurostents in these kind of situations. Now, we went from tandem to dissection, and one comment from Vincent about the technique in dissection. Anything you say, message to the youngsters when you're crossing or doing stenting, one something you have to really take care of.
Yes, maybe the idea of dissection is that everything relies in crossing the lesion, because the thrombus is always fresh. You should not expect like a hard clot, like a piece of stone, like a very bad thrombus to remove. The thrombus is extremely fresh. So if you go through this section, is 90% thrombectomy success. So the only thing you have to go is to go through. To go through, the idea that you should go with a big G-shaped catheter is a false idea, since you can jump into the false lumen doing this blindly, and then you can worsen the false hematoma and close the true lumen and close the case. So I advise you to be very gentle with the microcatheter, to make rotate your wire while you are crossing the lesion, and if you still stuck too long, it's that you are on the false lumen, so you can remove and try again. There is a tip and trick that is good to cross them, is to inflate the balloon guiding catheter, to push a little bit of contrast, to let the contrast like this, because slowly you may see one part is going in the false lumen and the other may show you the true lumen, so you just have, even if you're under local, to follow the stagnating contrast column into the true lumen. There is another tip and tricks by Jan Grala that is interesting. When
Yeah.
he cannot see it, he do a flow reversal into the balloon guiding catheter.
Yeah.
He called this the sailing technique because he's reversing a little bit the flap of the dissection before going forward.
Great. So, I mean, what on your trips to cross? In the first case, using the Terumo wire wasn't a great idea. We probably just made it worse. So, the last part on technical discussion is the ICAD, and just presenting a case, and then we can discuss. And this was a lady, you can see, left MCA infarctions. And you can see a tapered closure of the ICA here with great collaterals. Whenever you see something like that, we think whether it's ICAD because it already developed some great collaterals. If you see calcifications, you know much better. It was kind of slightly tortuous anatomy. And I think this is the diagnostic catheter and followed by our long guide over an aspiration catheter. And so if you even think ICAD, great collaterals again, but should we do a debulking? Should we do straight away angioplasty? I mean, okay, the literature says aspiration doesn't work very well. So we always do one pass of thrombectomy, all right, with a stent retriever. I mean, because aspiration catheter wouldn't fit into a tapered origin. It's better to do a thrombectomy if you're doing debulking rather than anything else. So that's the aspiration catheter along with the stent retriever. I wish I could have, okay. And then we take it out. And then the run shows that, yes, it's patent, but we can see the stenosis right there. One can wait for a while, but it's a tight stenosis. Do angioplasty and see if you can get away with it. Again, literature favors that patency is much better using stents and injectable agents. So now we know likely it's ICAD, the tapered origin we saw from before. We were planning for it. So as I said, one can do just balloon angioplasty. We can skip this part because of the time. One may think about direct stent, angioplasty, or just wait and watch with antiplatelet. But you know, tight stenosis, they tend to go. We waited for a while, it tends to close down in 10 to 15 minutes. At least they need angioplasty and some injectable antiplatelet agents in our experience. Okay? So, now you have to be ready for a stent placement. So, and we love to have guidings high up there. We do slow angioplasty with a very small balloon, and then we try to wait and watch in such situations. So Solitaire 440 was used previously, so that's a balloon being taken. I think initially we took a 1.5 millimeter balloon just to do a small angioplasty. My colleague Dr. Rajnivas had done this procedure, and small angioplasty, and then we see whether it remains patent with some injectable agents. But it wasn't, I've not shown the pictures, it was tending to collapse back. So we decided to go ahead with the stenting. Before placing the stent, we had done an angioplasty with 2 millimeter balloon. It's great to have your guiding up there at the bifurcation, if one can see this thing. All right. You can't get the marker in. And have guiding right at the IC bifurcation, as one can see there. All right. So what we did is CT before doing stent, just to see if there's too much enhancement or no bleed at that point of time. We injected antiplatelet agents, and in this case, one can debate between balloon mounted or self-expanding, but we used a credo stent here. Now, if you can see already, it seems we have placed it quite distally in the ICA. The proximal part wasn't really looking that well open. So initially the flow is now good. And usually we don't like to cross ever with self-expanding stents, but in this case, it felt the artery was collapsing back. I had no choice, so used another balloon, a new balloon now, and we crossed the stent again with a very fine wire. I used actually a avium wire, took a microcatheter across, exchanged with a Traxus because I didn't want to dislodge the stent, and then we did another angioplasty. I didn't reuse the older balloons which I have already used, and we did with another new balloon, 2 millimeter balloon, angioplasty of the stent. We kept the balloon there, took a run, it remained fine. We look at multiple angles. There was some spasm in the artery there. We did another CT on the table. You can see dense enhancement, but no bleed. And I think we did a check angiogram, which looked later on pretty fine. Okay? So clearly in this case, if you see, so coming to the ICAD, all right? So ICAD, as I mentioned, we do a thrombectomy one pass first. First is suspicion of ICAT, because straight away strategy changes. You have to be ready to get a guiding eye up. First pass with a solitaire. Literature says stent and injectable agents have best patency. But again, as I said, maybe our patients come in late and everything. We try with the angioplasty and injectable agents first. In this case, it was going away. Then the debate can be between balloon-mounted or self-expanding. We use a self-expanding, but we didn't deploy it well. And when we tried to retrieve it to position it right, we couldn't retrieve it, deployed it well. This was one exceptional case where in self-expanding also we did post-angioplasty as well. Ultimately remained patent. We did a check angiogram and everything. So this is how it is. But as I said, a lot of cases we do try just angioplasty, small angioplasty and injectable agents and try to get away in these patients. But the key is to expect is ICAT, because then you need general anesthesia. You need general anesthesia, you have to be ready to change your guidings and be ready with all these stents and balloons and everything. Matthew has a lot of experiences using just tirofiban and angioplasty, right, in these cases? Yeah.
Basically, again, follow the same protocol that we do for carotid stenting. We dilate it.
All right.
Using a balloon close to about 10 or 15% less than the size, and if the results are good, we would convert that to an elective rather than doing emergency stenting. It's purely from our bad experiences of bleed because of dual antiplatelets running, Tarofuse running and then converting it to dual antiplatelets.
Yeah.
Just one question. When you are waiting for this is invariably ICAT cases.
Yes.
When you wait after recanalization, it is invariably going to get occluded.
Yeah, that's the...
When you are waiting, will you keep the wire crossed? Because that time the lumen is patent.
Okay, so, once you've done just the thrombectomy...
No, it can never happen, Arvind, because we had done a stent retriever or a suction. So everything is out.
So everything is out.
So the wire is never there.
Yes, once you do angioplasty and everything, of course you keep the wire across. Because that time you're already into this PTA stenting mode. But initially, no. But we do inject injectable agents. We know if any chance of remaining patent is if you've got this is a ruptured plaque with a lot of platelet aggregation happening. So we start giving them antiplatelet agents for sure, because otherwise not going to remain patent, whichever way you do. Whether it's just stent or angioplasty or stent, you need injectable agents to keep it patent, in our experience.
Okay. My question was for are there cases with you that initially you have crossed the plaque, but later you could not, like dissections?
So I would say once you see clot formation, it closing down, cross it anyway. There is no point waiting for complete occlusion and then recrossing a plaque. So once we see it's collapsing down, flow is reducing, we know. And angioplasty is needed in this case anyway. It will be very rare just by thrombectomy they remain patent. So in fact, as soon as you do the angioplasty, until it looks great, unless the clot burden was large and plaque is very, very small, you may get away. Otherwise, angioplasty is almost needed. So we don't wait for complete occlusion. As soon as we see it closing down, we recross, do angioplasty, inject antiplatelet agents. I think the waiting stage is angioplasty and antiplatelet agents. At that stage, really the waiting comes in, whether we can get away without a stent or not. Yeah, to fail.
The only thing I think we need to be also careful when you get an ICAT is when you do a stent retriever, like what you did here, you're always potentially has a risk of rupture because you potentially have a stenosis. I had a rupture very recently. Have you
Rupture of the
experienced-
vessel, is it, to fail?
Yeah, so there was ICAT,
Oh.
and obviously you don't
We never had
recognize
that.
it, and you go across. And I think when you are not able to cross a lesion, it should highlight you again very quickly that you are probably dealing with an ICAT, and which wasn't recognized. I don't know what stent was being put, but I was there actually watching it, and I should have stopped it because he wasn't able to catheterize. And then he managed to catheterize, and there was I think it was a catch-mini which was used because it was M2, M1, and as soon as he pulled out, and we have had one or two ruptures in ICAT, not recognizing underlying ICAT, stentectomy, and as soon as you pulled out, you have a rupture.
Was it because of the M1, M2 location? Like, was it very distal into a smaller vessel?
No, proximal.
I don't know. I mean,
So have you had a rupture?
No, we haven't had a rupture. But again, I mean, Vincent is here, Dr. Matthew. I mean, the debate can be whether you're trying to say we go straight away with angioplasty first?
Dr. Tufel, the case you were telling, after the placing the microcatheter beyond the occlusion, did we took the microcatheter run, whether it was there in
true lumen
some of
also,
the
yeah,
true lumen or major branch, or it was in some perforator or something? Because beyond the clot, we cannot see anything.
So the latest case I remember very well. It was an M1 occlusion. There was a good collateral. The microcatheter, and I have a very experienced registrar who was doing it, and the microcatheter was not going through, and I should have taken over. I did not take over, and eventually managed to catheterize distally. Did the distal run. M2 was okay. And then I said, yeah, put a stent in, which is when I should have realized that there is underlying ICAD, which I did not realize. And then as soon as the stent was pulled, boom. Okay, and there was a rupture on table.
So, I don't know.
So
okay,
I'm
we don't do that many thrombectomies. Maybe Vincent can say whether he had a rupture.
No, I think it's uncommon in ICAD when you are in the true lumen to have the rupture. I don't remember rupture. We had ruptures in different situations, but not in this one. I think it's possible also to have a false trajectory into the plaque, and then to make a thrombectomy and to cork the plaque and then to rupture the vessel, probably. But I've never seen that in our center at the moment on ICAD. Of course, we had rupture in different settings.
So,
and the fact of debulking the lesion first is still very important, because when you have an ICAD, and this is also what we need to say to the students, you have two problems. You have the ICAD, and you have the clot inside the ICAD that has finished the job. And if you just make a plasty first line, and what I did sometime in the learning curve, I just went for direct plasty, you can embolize the clot that were inside the ICAD distally in the vascular artery. So the need for debulking is still there. And if you hear the Chinese guys that are doing a lot of ICAD, and they compare aspiration with stent retriever, again, the stent retriever is much more efficient to clean the ICAD than the aspiration. So I think we still need to debulk, to advise to debulk those lesions, because if you do not, then you send the distal emboli into the circulation.
See, you can have a rupture to fail, in a hard eccentric plaque,
okay, so
where the normal vessel dilates and the plaque doesn't, So it can very well happen in an ICAD,
right. So,
because here we are not really able to image and know whether it's an eccentric plaque. You may have a 80% or a 95% stenosis, and most of the plaque is on one side, so you can definitely rupture, But
No, I know, and I think
just one thing to fail. I'm sorry, guys. We'll have to just carry on. And to me, the only question in this case was, we can just have a voting here. Should we have used a balloon-mounted stent instead of the self-expanding? Ajay, balloon, self-expanding. This one.
For which case?
This one, the case which we showed.
Which you showed.
Yeah.
I honestly feel that it doesn't make a big difference.
All right,
Seriously.
no difference. Vincent, balloon mounted or self-expanding?
Why not a simple balloon?
We did a simple balloon, it occluded.
Simple drug-coated balloon.
It was occluding with the balloon angioplasty.
He said it was not staying open. I mean,
So
what
Vincent,
he's saying is...
balloon mounted stent or self-expanding, what would you use?
For me, M1 is coronary stenting.
Coronary stenting.
Yeah.
Yeah.
So balloon mounted from my side.
for me it's coronary stenting because I had occlusions with credo.
Yeah. Arvind.
Coronary.
Yeah, I mean, yes, our guiding was right there.
So
maybe
again,
coronary,
see-
because we landed in trouble even after stent placement.
But
which
wouldn't
wasn't
you see,
acceptable.
is it in the mid-egment where all the perforators are there? See, if you're going to use a coronary stent in a segment with the perforator, the chance of pushing plaque is much higher. So
That
I
is
think
also
all
there.
these are matters
So-
we just can't have one shot for everything.
You agree. We also end up, it's very easy, convenient, but they are more costly. But yes, with balloon, you get a very good lumen and probably patency rates may be higher. We'll know the answer. But yes, internationally, balloon mounted stents are favored. When we are not so experienced, we use self-expanding. But our mistake was length of the stent and delivery of the stent in this patient.
See, a
That
credo
was
is
a
an
mistake.
absolute no in the carotid siphon
All right.
because it's
Okay.
the worst in there. It will not even expand.
Okay.
So in some other segments, I don't think it makes such a big difference.
All right, so we just, I know we are running very late. Dr. Padma is here for the next talk.
We have tried few drug-eluting balloons in the same location in M1, and
But
they
in
have worked
acute
wonderfully.
case,
Yeah. acute case.
Okay, that's a thought, and we
Simple
can...
drug eluting first
All
with a
right.
1.5 mm
So-
balloon followed by another 2 mm balloon.
Lovely. Okay.
No drug eluting.